Part 2. Your Therapy. Chapter 4. Recovering your mobility. Usually, the most noticeable effect of a stroke is paralysis or weakness on one side of the body. This is called hemiparesis, which means half weak, or hemiplegia, or half paralyzed, and it can make it difficult to walk or even stand up. The weak or paralyzed side of the body is called the affected side. Remember, one side of your brain controls the opposite side of your body. So if the medical team calls your stroke a right CVA, they mean it's a cerebral vascular accident in the right hemisphere of your brain, even though you'll notice it on the left side of your body. Building up strength and control of your body is a top priority after a stroke. Dr. Michelle Plomin, a neurological physical therapist and top neurorehabilitation researcher, shares her expertise on how you can maximize your physical recovery and mobility. Question 19. What are the common physical effects of a stroke? Dr. Plomin. Strokes are quite variable from person to person. It depends on what side of the brain and which specific areas are affected. Most commonly, we see an inability to move the limbs on the affected side due to paralysis. Sometimes people experience spasticity, which means the muscles have too much activation. This is caused by the brain not being in full control of the muscles. It can be painful with spasms and tight muscles. Along with weakness and paralysis, there can be sensory loss. You feel numbness and tingling in your hands or feet, and you don't have a good sense of where your arm or leg is in space. Question 20. How can physical therapy help stroke survivors? Dr. Plomin. After a stroke, the brain goes through a period of inflammation and then repair. We call this spontaneous recovery. As inflammation within the brain subsides, movement on the affected side begins to emerge. This spontaneous recovery usually happens first in the midline of the body, so in the trunk and the hips first, and then it spreads to joints farther out from the center, such as the knee or elbow. Physical therapists have two main roles. First, they want to encourage more spontaneous recovery, so they help the person with a stroke use the affected side as normally as possible. You might think that would be fairly simple, but it's not. Because humans are optimizers, in order to function in our world successfully, we use the abilities we have. So after a stroke, we tend to use our stronger side more and our affected side less. Physical therapists work hard to promote symmetry, which is the equal ability on both sides, and to get the person with the stroke to use the affected side as the spontaneous recovery happens. The second role of the physical therapist is to strengthen the weak muscles. Perhaps they are improving and recovering, but they're weak, so they need to be strengthened. The muscles need to learn when to turn on and off at the right time for agility and coordination. Balance has to be retrained, as well as the ability to move around and do functional tasks like rolling over in bed, standing from a seated position, walking, and climbing stairs. All those motor programs stored in our heads are lost because of a stroke, and we need to relearn them. Author's note. In addition to therapy, doctors may be able to help with spasticity by giving injections of Botox. The same medicine used to remove wrinkles on your face can be used to relax tight muscles without the drowsiness caused by oral muscle relaxers. Botox can be injected directly into the tight muscles that are causing you the most pain. Question 21. How can exercise help with stroke recovery? Dr. Plomin. Exercise is really the foundation of stroke recovery. It's absolutely essential. It's important to know the different types of exercise since not all exercises are created equal. In terms of neurorehabilitation, we think about three main types of exercise. One is intensive task practice. Take an everyday task you want to focus on, for example, reaching for a pen or a cup. You break that task down into the components of the movement and then practice the components thousands of times. Then you put the movement back together. Another type of exercise is strengthening a weak muscle. You challenge the muscle so that it gains the power to hold and support the body. The third type is aerobic training. What we know is that people with strokes have reduced functional capacity, so they feel tired doing everyday tasks. You need to do aerobic training to build your functional capacity so you can walk for long distances, for example, like getting across a large parking lot. If you have a stroke, your physical capacity is lessened and you're not able to do as much, so your aerobic fitness goes down. Then, when you try to do a task, you feel more fatigued, so you do less, and it becomes a vicious cycle. What you need to do is focus more on aerobic fitness. It will hopefully increase your capacity to do activities and decrease your fatigue, so you'll be able to do more.
A stroke survivor says, "I'm in a wheelchair. How can I exercise?"
Dr. Plomin, exercising from a wheelchair is certainly a challenge. Because your trunk is supported by the wheelchair, you're not free to move as easily as if you were sitting in a kitchen chair. If you're in a wheelchair, you can remove or flip aside the footrests to try to propel the chair forward and backward with your feet. This can help improve the coordination and movement of your legs. Done on a flat surface, it can help your timing and coordination, which is important for walking. If you try the same activity on a slope, it will improve the power of your leg muscles and also bring in your abdominal and back muscles. However, it would be better to transfer to a regular chair or onto a piece of exercise equipment than stay in the wheelchair, if that's possible for you. Author's note: there are many ways to perform aerobic training without walking, running, or playing sports, the things we typically think of as ways to get the heart rate up. You can use an arm or leg ergometer or pedaler, ride a stationary bike, swim or walk in a pool, or do chair aerobics, and there are classes and videos for this. As you regain your strength and mobility, you can add activities like climbing stairs, rowing, dancing, or cycling. A recumbent tricycle is popular with stroke survivors who want to get exercise outdoors. Question 22. What can stroke survivors do at home to improve their walking? Dr. Plomin, what research shows us is that the best way to improve walking is to walk. The theory is that it is task-specific training. The brain has motor programs that have already been formed for this task. So to access and train those programs, you have to train specifically for what you want to do. For example, studies have shown that practicing walking over ground is better than walking on a treadmill. Because ground is the real world, your body and brain remember how to do it. You need to find ways that you can practice walking at home that are safe. Think about a short, safe space that you can walk along, either by holding on to another person, holding onto your kitchen counter, or using your cane and your kitchen counter. First, you practice walking a small distance that you know is safe, a distance where your risk of falling is very, very low. If you're really unsteady, you might think turning around is a tricky movement to do. In this case, practice walking back and forth without turning around. Walk backward 5 or 6 steps, then ahead 5 or 6 steps. As you feel stronger and more confident, you're going to add to your distance by walking more laps back and forth. Then you will gradually begin to loosen your hold on the counter or a helper's hand, or switch from a rail to a cane, and from a cane to no cane. But be patient and build on your walking skills over time. It could take months or even years to reach your goals.
A stroke survivor says, "The doctor said I'll probably never walk again. Is that true?"
Dr. Plomin, I don't think anyone can tell a person that he or she won't walk again. There is always hope that you can. I'm a physical therapist as well as a neuroscientist, so I would ask, why can't you walk? I would have to assess the person with the stroke to know. Is it because there's spasticity in the limbs that prevent the muscles from moving properly? Is it because the person has contractures or tightness in the joints and the joints won't flex or move? Or is it because the person has fatigue and low aerobic capacity, so he or she can't tolerate this exercise? Or is it poor balance? You have to find out the reasons why and then focus on improving those pieces to get back to walking. Question 23. How does a person know when he or she is ready for a new walker or cane? Dr. Plomin: One way to know is that you feel it. As you're working on your walking, you'll start to feel a sense of confidence. Your confidence is saying, I think I can actually stand here with one finger support, or I don't need this white-knuckle death grip on a cane. Once you get the sense that you're not putting much weight through your hand, or that your hands are really doing very little, you can start to reduce your base of support. Think about your walker and cane as a base of support. A big walker with 4 wheels or 4 legs has a huge base of support. A support that you need if your legs don't work properly and you have to use your hands to support yourself. If you feel like you're not using that base of support, you can probably move to a cane that has 4 points on it. Maybe that's enough. It's only a third of the size of the walker. Then if you feel that you're solid on the 4 legs of that cane, then you're not really using that cane that much. You can just go with a single point cane. Question 24. What is foot drop? What can be done about it? Dr. Plomin: When you hear the term foot drop, it sounds pretty straightforward. The foot just drops. Actually, foot drop is complicated because it can be caused by a lot of different problems. There are 2 stages to walking. First, you put your weight on your leg, and then you swing your other leg through. With foot drop, the problem is that as you swing the affected leg through, the foot drags along the ground. This could be caused by weakness in the muscles in your shin that pull your foot up to clear the floor. It could be tightness in your calf muscles. An overactivation of spastic muscles in the calf can make the foot point downward and cause the toes to drag. Or it could be that the hip, knee, and trunk are not lifting the leg high enough. Treatment for foot drop depends on what the problem is. There are some new devices on the market that stimulate the muscles on the front of the leg to lift the foot. So if the problem is that your foot doesn't lift, you can use muscle stimulation to help lift the foot. Sometimes the answer is a splint. You can place a splint inside your shoe to keep the foot up so that it doesn't drop down. This is called ankle-foot orthosis, or AFO. But there is a downside to using an AFO. When you're trying to promote recovery in your ankle, having a splint to stop the ankle from moving isn't good. It's much better to practice and see if you can get that movement back without a splint. If you're experiencing foot drop, you can meet with your physical therapist to determine which of the causes are responsible for the foot drop and then determine an appropriate treatment.
A stroke survivor says, I have the feeling of pins and needles in my leg all the time. What can I do about it?
Dr. Plomin: Many people with strokes have this feeling of buzzing through the limb as though the leg is asleep and just waking up. It's often because the stroke has affected the sensory areas in the surface of the brain or deep within the brain, and it can be really annoying. There are 2 approaches for treatment. One is medication, so talk to your doctor about that. The other is a physical and sensory approach. The gate theory of pain proposes that your body can process only so much sensory information at one time. So if you touch, squeeze, or apply heat or cold to the limb, it can trick the sensory system into reducing the pins and needles feeling and starting to feel the other sensations. Try to use your leg as much as possible. The brain is trying to rewire, and these pins and needles are sometimes caused by excessive plasticity, connections being made that are not helpful to you. So you want to give the leg as many normal sensations as you can. Pressure, touch, standing, putting your weight through it, cold, heat, all those different sensations. Question 25. How can stroke survivors maximize their physical recovery? Dr. Plomin: What we know about stroke recovery is that intensity matters. You have to practice certain movements thousands of times to regain and improve them. It won't happen by sitting down and doing nothing. You really have to map out that time to do it yourself or get the help of a therapist and engage all your family members. Those people who come by and say, "Can I give you a hand? Is there anything I can do for you?" Tell them yes. Ask them to do activities with you so you can practice. You have to take advantage of the family and friends who are all around you offering to help. They often want to help, but they don't know how, so they bake cookies or send flowers. Instead, you can put them to work helping with therapy through some very concrete tasks. If someone could just stand by you while you do your arm or leg exercises, that would be a tremendous help. We know that the formal therapy you need is not always available. Even when it is, you maybe get 5 hours of therapy a week, but there are at least 12 waking hours in every day. What are you doing for the rest of that time to promote recovery? In your first 6 months post-stroke, your brain reverts back to a developmental stage. A lot of the proteins required for plasticity are strongly present in the brain in those first 6 months, so that's when you want to capitalize on everything around you. Have your therapists map out activities for you to do. Beyond the hour or so you spend with them a couple times a week, take more hours, up to 6 a day broken up into periods, and work hard on your rehab during that 6 months when plasticity is at its highest. Question 26. What can be done to prevent falls in stroke survivors? Dr. Plomin. Falls are very common in stroke survivors and can be devastating because they can cause further injury. About 30% of people who are discharged from the hospital after a stroke will have a fall. Falls usually happen in the home. The riskiest time is in those first few weeks after discharge for people who use a walking aid or need assistance when walking. Falls are also more common in people who have depression. Prevention is always better than cure. To prevent falls, especially in those first few weeks, you must make sure you have the assistance you need when you're moving. Falls usually happen when you let your mind drift for a moment, when you're in an unfamiliar environment, or when you're rushing. Plan out your movement. Look at your space, picture movements in your mind, and make sure you have enough help and the right footwear and equipment. Remove throw rugs, relocate any wires or cords in your walking path, and move side tables or lamps that may get in your way. Bathrooms are a common place for falls because there's limited space and there are multiple obstacles around you. Install a rail or two in long hallways and put grab bars in bathrooms to help. Takeaway points. A stroke can leave you with a number of physical problems that can be helped by physical therapy, such as paralysis or weakness, spasticity or tightness, sensory loss, decreased aerobic capacity, decreased balance. There are 3 types of exercise that are important to do. First, intensive task practice. Second, muscle strengthening. And third, aerobic activity. The best way to improve walking is by walking. Find a safe place to practice taking a few steps, then build on that. As you build strength, you can reduce how much support you need from walkers and canes. Talk to your doctor and physical therapist if you're experiencing the common post-stroke problem of tingling in the limbs or foot drop. Ask family and friends to help you with your exercises. You need all the practice you can get for a better recovery. Prevent falls before they happen by removing barriers and clutter, installing rails and safety equipment, and planning your movement before you start. Chapter 5. Recovering your arm and hand. While losing your mobility can be devastating, it can be equally frustrating, if not more so, to lose the use of your arm and hand too. Our daily lives seem to require 2 hands to do just about everything: dressing, washing, cooking, working. We talked with 3 top occupational therapists and researchers to bring you answers about recovering the use of your affected upper extremity, or your arm and your hand. Dr. Mary Ellen Stoikov is a researcher in the area of post-stroke upper limb hemiparesis and a professor at Rush University in Chicago. Dr. Glenn Gillen is a professor at Columbia University who literally wrote the book on stroke rehabilitation, 2 textbooks, and countless other publications. And Dr. Stephen Page leads the Brain Lab as a professor at The Ohio State University and co-developed the Stroke Specialist Certification Program for Rehabilitation Therapists. Question 27. Why is it that the paralyzed arm and hand seem the slowest to recover? Dr. Stoikov. The middle cerebral artery is most commonly affected by stroke, and that artery covers a huge territory in the brain, which includes the area that controls the hand and the arm. We have more cortex area in the brain for controlling the hand and the arm than we have for controlling the leg. The reason is that our hand and arm movement is very sophisticated. It's harder to rehabilitate very complicated movement where lots of joints are involved than it is to rehabilitate walking, which is mostly hip flexion and knee extension. Walking is complicated, but arm movement is much more complicated. An everyday action such as picking up an empty cup requires a lot of movements. First, it requires movement in the shoulder. Then the elbow has to straighten. Next, the forearm has to be placed at the exact angle in order for the hand to position itself and bring the fingers around the cup in the right size and shape. It's not as simple as it might seem. Question 28. What can stroke survivors do to get their hands working again? Dr. Stoikov. One approach I advocate is sensory feedback into the hand. If you don't have movement, I would flood that hand with sensory feedback, rubbing a towel on it, applying vibrations, putting it in uncooked rice. We have connections in the brain that run between the sensory and motor cortices. They're very intricate connections, and sometimes when we massage or stimulate the sensory system, all of a sudden we see movement. We take advantage of the two-way street between the brain and the hand. Even if the hand is not yet ready to move when the brain signals it to, you can put sensation in that hand so that it sends a message back to the brain to strengthen neural connections. An occupational therapist can help you figure out things you can do in your life to get your arm moving. If there's no movement or if the task is unsafe, there may also be one-handed techniques you can learn. But I'm not a fan of starting with those right away. It's use it or lose it. So you really want to try to yin and the hand. Even if the hand is not yet ready to move when the brain signals it to, you can put sensation in that hand so that it sends a message back to the brain to strengthen neural connections. An occupational therapist can help you figure out things you can do in your